Welcome to Pleasure in the Pause, a podcast dedicated to empowering midlife women to connect with their bodies, pleasure, and power in perimenopause, menopause, and beyond. I am your host, Gabriella Espinosa. Each week, I sit down with leading medical experts, thought leaders, and trailblazers for bold, thought-provoking conversations that educate, inspire, and challenge the myths we've been taught about our bodies, aging, and sexuality. I also share solo episodes with evidence-based insights and real talk to help you feel informed, supported, and in charge of your health and pleasure in this season of life. Because your pleasure matters in and out of the bedroom. So take a deep breath, settle into your body, and let's begin. Hello, beautiful listeners. Welcome back to Pleasure in the Pause. If you're a woman in your 50s or 60s who's done all the right things, you eat well, you move your body, you try to manage stress, and yet you still find yourself wondering, is there more I could be doing to protect my health for the long run? Not just to live longer, but to live stronger with vitality, confidence, and energy in this next chapter of life. That question is at the heart of today's episode, because midlife is not the beginning of decline. It's the beginning of design. The choices we make now shape how we experience the next 20, 30, even 40 years of our lives. And in this episode, we're going to build your midlife vitality blueprint, giving you practical tools to become the CEO of your own health. My guest today is Dr. Noor Al-Humaidhi, a board-certified family physician, menopause specialist, and founder of Lifestyles by Noor. Dr. Noor brings a unique blend of clinical experience that shapes the way she approaches midlife health. She has worked in primary care, hospice, and geriatric care, giving her a front row seat to how women age when prevention isn't prioritized. Today, her work focuses on menopause care, lifestyle medicine, nutrition, and whole person wellness, all under one roof. What makes her work especially compelling is that her journey into menopause care began personally. Despite being a physician, she was caught off guard by her own perimenopausal symptoms and found herself searching for answers. That experience sparked a deep dive into menopause science and ultimately inspired her to create a new model of care for midlife women. In our conversation, we explore what it truly means to approach midlife with intention, from prevention and lifestyle medicine to the key health markers every woman should understand and the practical steps you can take right now to protect your vitality for decades to come. This conversation is practical, it's empowering, and it's an invitation to take ownership of your vitality in this season of life. Let's dive in and welcome Dr. Noor to the show. Welcome to Pleasure in the Pause, Dr. Noor. It's such a pleasure to have you here.
Thank you for having me. It's great to be here.
We first connected on social media where you have a large and very dedicated following. I love how you share evidence-based medical information in such a real, relatable, and accessible way. I'm excited to invite listeners into your world and make this conversation feel practical so women listening walk away knowing how to build what I'm calling their own midlife vitality blueprint.
That sounds amazing. What I want to always communicate is that you have the power, you have the understanding and the knowledge. As long as we listen and we communicate and we have shared decision making, this is not scary. It should not be scary.
Yeah, I'm excited for our listeners to hear everything that you have to share. So you began your career in primary care and now specialize in menopause, lifestyle medicine, and whole person care. I think you bring such a unique angle having started off as a primary care physician. And I'd love to start right there because what makes your work so significant is that it grew from your own lived experience of being caught off guard by your perimenopause symptoms, not necessarily originally trained in this lane of menopausal care. Can you take us back to that moment and how it changed the way you practice medicine today?
So I, started perimenopausal symptoms relatively early in my 30s, but things really changed. It happened to be at the beginning of COVID. I started to have terrible anxiety. I was still working in primary care. They had shut down our primary care office and moved us into what they called a respiratory clinic. So we were seeing COVID patients all day. We didn't have PPE. It was incredibly stressful that very beginning of COVID. And I started to have just awful anxiety, waking up in the middle of the night, having intrusive thoughts. I thought people were in the house. And I thought I had COVID, long COVID. I was anxious. I was stressed. I was writing it off, thinking, no, it's fine. It's something, this is normal, my normal reaction. And it just progressively got worse. My brain fog got worse. I always tell people my brain just stopped working. I had gone from this very high achieving person that was very methodical in her approach and taking an exam, approaching anything. I was methodical. I had all the steps in my brain. I would go 1, 2, 3, 4, and that ability disappeared. I couldn't even put two thoughts together. Was trying to study for an exam and I just couldn't read and retain. This had never happened to me before. So then I was like, okay, this is long COVID. Maybe this is MS. What is wrong with me? And I started to see doctors, my own primary care physician. I was referred to a neurologist. Then ultimately landed in a psychiatry office and they treated me for anxiety and depression, which I don't think on reflection I had anxiety and depression, but I was clutching at straws at that point. And I started to take some SSRIs and had terrible reactions to it. And I was up in the middle of the night and scrolling TikTok or Instagram, I don't know. And suddenly I saw something about brain fog and perimenopause, and that I had this click, the whole thing clicked. And I thought, my God, this is menopause. And then I know that my mother went through menopause early. This opened up this Pandora's box of information. And I joined the Menopause Society. I started to read. I read everything. I read Estrogen Matters, which is a life-changing book. I can honestly say I've never read a life-changing book like that, like Estrogen Matters. It literally altered the course of my life and realized what I needed was hormones and then tried to get my hormones, but nobody would prescribe them because I was 38 years old. And so I prescribed them for myself, which is frowned upon, but you can do it in the state of New Hampshire.
Mhm.
And it was overnight. I would say 48 hours, I was sleeping and my intrusive thoughts and anxiety were gone. But still a work in progress. And I'm fiddling with doses. I'm now 43. I'm fiddling with doses here and there, but it was life changing. I was on the road to not being able to practice medicine anymore. That's how badly I felt. And
Mm.
it literally saved me. So that sent me on this. I said, I'm going to have to bring this to everybody else. And I started my little practice. I worked at the time 3 to 4 days a week. And I thought, I'll just work 1 to 2 days a week just to bring this care to other people. And that just took on a life of its own. Here we are.
So you're confirming what we hear a lot about, that your average doctor, your primary care physician isn't trained in menopause or probably isn't
I
trained to recognize the
had
symptoms of
no
menopause.
idea. Honestly, and I think back on this and I think, how could I not know? And sometimes I think about the things I said to women and it just makes me just want to cry. But I
Mm.
had no idea. I did not know. I was thinking hot flashes and night sweats. That's what it was. Brain fog, anxiety, mental health symptoms, weight gain. I had no idea.
I also learned by looking at your beautiful website that before focusing on midlife women, you worked in hospice and elderly medicine. So you had, correct me if I'm wrong, before you went into menopause care, this front row seat to how women age when prevention isn't prioritized. What did you witness that shaped your urgency around menopause and midlife prevention?
People say that women live longer than men on average, but I can tell you that women are living badly in their late 70s and 80s. And even those that live into their 90s, yes, there are outliers. There are some that are very healthy and doing very well, but the majority of women have lost their independence. And I spent a lot of my time, especially when I was in the UK in primary care, we would geographically, that the practices that I was attached to, we would geographically cover nursing homes in our area. So one of us would go and would do a ward round at the nursing home. I had a front row seat. Those nursing homes were full of women who were falling, who were frail, who were having recurrent UTIs, who were cognitively impaired, and they could not live alone. They did not know where they were. And that some of them lived that way for many, many, many years.
Yeah, and many of us are at that life stage where we're caring for our elderly parents
Mhm.
who are at that age. I've visited quite a few nursing homes myself in planning for the future of my mother. And I just leave those places in tears, so depressed. And I just can't take her there. So I'm doing everything to look after her. And also to think I need my nursing home prevention strategy now. So I want everyone listening to imagine us living as thriving 80-year-old women, because we can do that. Dr. Noor is going to walk us through that. Let's talk about what we can do differently in our 50s, 60s, 70s. And a lot begins with lifestyle. I love that your clinic is built around lifestyle medicine. So, for listeners who aren't familiar with that term yet, can you explain what lifestyle medicine looks like in real life for midlife women?
Lifestyle medicine is built on this idea that your lifestyle is medicine and you can alter the course of your life from a medical perspective with lifestyle interventions. And I would say the single biggest thing that you can do to alter your lifestyle and the course of your health long term is to exercise. Number one, keep moving. Number two, lift heavy weights. We need muscle mass. When we start falling, it's game over. And I say this not just to women, I say this to men. Have a lot of patients that have Parkinson's disease that come and see me, men. And I always say, once we start falling, it's over. The biggest thing you can do to stop yourself from falling is exercising and lifting weights. Those are the two, I would say, top priorities. And people think, oh, you mean, 5 pounds? No, I don't mean 5 pounds of weights, 40 pounds, 50, 60 pounds, heavy weights. I want you to be on a weight loss program that involves lifting heavy, ideally, ultimately in a farmer's carry, lifting 75% of your weight. So for me, that's about 95 pounds split between two hands, walking across a room for a minute. It's really hard, but that's the goal. When I start to say things like that, people are like, oh my goodness, 40-pound dumbbells. That's crazy. But that's actually where we want you to get to. We're not talking about 5, 10, 12 pounds weights. We're talking about really heavy weights to build muscle. So that would be the biggest intervention. Number two would be social interaction. You must have a community. Isolation, we've seen these in studies recently, the impact of isolation on our longevity and our risk of chronic disease. So community isolation is our enemy, especially for women. So exercise, community, and diet. I hate the word diet. I generally use the word nutrition in our practice because I think it's such a terrible connotation. But nutrition, so making sure that we are fueling adequately. Currently, the group of women that are in their late 70s and 80s are the women that we call the almond moms. They were the diet generation. They were the women that didn't eat, that had a half a clementine and a handful of almonds for lunch. My generation were raised by those women. And I'm seeing the outcome of that for their bones, for their muscle mass, for their brain, for their dentition, what happens when you don't eat adequately. So number one, fueling adequately. And number two, whole foods. So trying to avoid as much as you can. And it's really hard. And I get it. And I talk to patients about this all, but trying to avoid processed foods as much as we can and sticking to whole foods where you're able. We're not trying to create some sort of completely new nutrition plan, but really trying, when possible, to substitute whole foods instead of things that you might buy in a can or a packet or something plastic.
And I know that in your practice, you incorporate those lifestyle elements with coaching. You have a nutrition coach, you have a life coach, you have a mindfulness coach. You really incorporate those lifestyle factors into your practice, which I think make it really convenient, because we were talking before we logged on to the recording that sometimes we're just grasping for all these pieces and not knowing where to go to. So to have them all centralized in one place is so helpful. I also want to say that if it feels or sounds overwhelming, these lifestyle components, you can start baby steps. You were talking about the farmer's carry. I was told the same thing too, the farmer's carry. And I was like, there's no way I'm ever going to be able to do that. But I started a year ago. And so a year ago of consistent 3 times a week weight training. And I've gotten to a point where I can carry my own weight in farmer's carry for about a minute.
It's amazing.
It takes time. So I just want to encourage everyone that if this feels overwhelming, it is doable. You just take baby steps.
I agree. And everything is baby steps. We talk about a lot of things when people come and see us. And that's why I have all these I say to people, okay, let's just focus on this little bit. Let's do this for the next 2 months. And then we can do the next thing over the next 2 months. we have a relationship that's going to be a long-term relationship. This is going to take a year, like you said, it's going to take a year, 2 years, 3 years to get you to where you want to be, whether that's for your cardiovascular risk, whether that's for your bone density, whether that's for your muscle mass. And it's important not to get discouraged if you feel like you're not seeing results in the short term.
And that's where I feel health coaching, lifestyle coaching, or nutrition coaching comes into play. We've talked about it here on the podcast before that health coaches are so great at helping you change your behavior over time, establish those healthy habits so you change your behavior that can feel daunting, right? It really does help to have someone walk by your side as you're making those big changes. And then when you're able to fly on your own, you have all the tools and healthy habits on board. I love the fact that you incorporate that into your care. So let's make this even more practical, because women aren't just patients. And you stated at the beginning that we have the knowledge, the know-how. We can be the CEOs of our own health. So when a woman comes into your clinic and says, either I don't feel like myself, they're probably entering perimenopause, or they've done all the things, they're doing all the things, and they really want to optimize and stay healthy long-term. Where do you start? What labs, scans, or diagnostics do you run first to understand her baseline health?
With labs, I do an inflammatory, so something like a high sensitivity CRP. I occasionally do something called myeloperoxidase, which is a little bit more specific to our cardiovascular system. So those are inflammatory markers. So I'm trying to get a sense of what level of inflammation we've got going on, that chronic inflammation that comes with menopause and the loss of estrogen. So we'll do that. I do a full metabolic risk panel. So that's a complete lipid panel. So full cholesterol, but also we do apolipoprotein B and lipoprotein little a, which are two lipid parameters that are really useful for assessing risk, especially from a genetic perspective. I also do something called an insulin resistance score. So one of the things that makes me really crazy is that people are saying to me, "Oh no, I'm not pre-diabetic. My blood sugar is normal." I don't care what your blood sugar is. Your blood sugar being normal, you could be 2 years away from a type 2 diabetes diagnosis and have a blood sugar that's normal. Your blood sugar that's normal on its own means nothing to me. So I like to do a blood sugar, a hemoglobin A1C. We do a fasting insulin and C-peptide, and we calculate what's called an insulin resistance score. So that gives us an idea of whether or not you're insulin sensitive or insulin resistant, or where you are on that scale. We'll then do vitamin D. We'll do all your iron parameters, B12, full blood count, kidney function, liver function, generally all your hormones. So I usually will do cortisol. I'll do FSH, LH, estradiol, total testosterone, free testosterone. I will do a progesterone. I occasionally do something like a prolactin. Sometimes I'll add a few things. If somebody says something to me and I'm wondering, sort of alarm bells are ringing, what's going on here? I might do a little bit more in depth in terms of an endocrinology workup. I'll do occasionally a parathyroid hormone. So I really try to do a pretty scattergun effect. So I'm looking for any obvious nutritional deficiencies, anything obvious on her. In hormone labs, generally the hormone labs will look normal. And I say this to people, I'll do their hormones and they'll get the result before they see me for their follow-up. And they're like, well, I was disappointed. My hormones are normal. Hormones are normal mean nothing. I don't do the hormones because I'm making the decision whether or not to treat you based on your hormones. I'm actually often treating them before we do the labs. But I do the hormones because I'm looking for outliers. I want to see, is there something really weird going on here? And I've diagnosed all sorts of weird things. I've diagnosed Addison's disease. I've diagnosed Cushing's syndrome, very relatively rare hormone issues based on these labs that we get. And that's what I'm looking for. I'm just trying to make sure that there's nothing weird and wonderful that I need to be looking for. Additionally, the fact that your hormones look normal does not preclude you from treatment. And invariably in a perimenopausal woman, her hormones will look quote unquote normal. I talk about this on Instagram quite a lot. So I do try to get a very scattergun approach. Blood sugar is a big one for me. I'm finding insulin resistance in women you would never imagine are pre-diabetic. When you think about the diagnosis of type 2 diabetes, and if somebody has a diagnosis of type 2 diabetes over here, those changes in their metabolic parameters started 12, 15 years prior. So what we're trying to do with that insulin and C-peptide and that score is intervene here. Because if we can intervene here, we're going to prevent the diagnosis entirely. And that's the goal.
So those labs that you just mentioned, are those the standard labs that a woman going into her PCP would receive, or should she ask for those specific labs?
You'll need to ask for those specific labs. So here's the thing, and I've been toying with how to communicate this effectively, but people say to me, I can't get my PCP to order it. Number one, often the labs aren't covered, which is why in my clinic, I cover the labs. They're included in the membership because what was happening was I was ordering a big lab panel. They were going to Quest or wherever to have their lab and then getting a $3,000 bill because their insurance wasn't.
Mhm.
So I negotiated my own rate. And then, so all the labs are paid through us instead of anything hitting their insurance or being sent to the patient directly. But I will say that the best thing to do is to go online, get any of, whether that's LabCorp or Quest, and you can just go online and actually buy your own lab panel. You do not need a doctor to order it for you. You can go online, you can choose what you want to have ordered, you can bring your list, and it will give you a cash sum, whatever it is. And generally, if you do it that way online and prepay for it, it's significantly cheaper. It will generate the order for you and you will just bring it to one of the lab draw stations and have that drawn. So you do not need your PCP to order labs for you. You can essentially order labs for yourself.
And then when we receive those labs, what do we do with them?
The thing about hormones is your hormones are going to look normal. The fact that your hormones are normal doesn't mean anything. If you're perimenopausal and you don't feel well, you need to seek help with your perimenopausal symptoms. But what you're trying to, again, look for are outliers. Is your vitamin D low? Is your B12 low? Do you have really low iron? Is your ferritin really low? Those sorts of things that are maybe fixable from a diet and lifestyle perspective so that you can, even then, if you take that into your appointment, you have a little bit of ammunition and what you want your PCP or whoever you're seeing to focus on because you've already gotten the tests. My experience is that when people bring, can you order these tests for me? The PCP's hackles come up. And I'll tell you why that is. It's because they're not going to be covered. And it's because what's going to happen is the PCP is going to get blowback from the insurance and the organization because the labs aren't covered.
Yeah.
And I'll tell you what that looks like. Reams and reams of fax documents that we then have to try to write all different codes and then send it back. And then they send it back to us and send it back and say, nope, that's not covered. It's ridiculous and the biggest waste of time, but takes hours of time to try to resolve these issues. But that's why it's such an issue when going into PCP's office because of it not being covered.
I think also in my own experience, giving your insurance a call beforehand, right? And saying, are these covered? Or going to, like you said, a LabCorp and paying for them yourselves. Because if it's a one-time investment where you're going to get this very whole picture of your health. And so when you say most people's labs around hormones come back normal, you go by symptoms really to treat hormones. Is that right? Is that the standard of care?
That's the standard of care. I do labs and I will continue to trend labs. But yes, your hormones will look normal, but that doesn't tell me that your hormones are normal. So it doesn't tell me that your hormones are normal at the cellular level and your hormones aren't causing your symptoms. So just because your hormones look normal doesn't mean I won't offer you treatment.
Okay. So you look for the most pain point symptoms that they're coming in with.
Yeah. And usually it's sleep. Very commonly, sleep is the big one. I don't feel like myself. I'm anxious. I feel like I'm living in a fog. Those sorts of more neurological symptoms. Women do have hot flashes and night sweats. And sometimes there's women that are having hot flashes and night sweats 20, 50 times a day. But the majority of women aren't. The majority of women can't sleep.
And then going back to your own story, that brain fog really is just
awful.
So persistent.
And there's women out there that are leaving their profession. They're making decisions. They're taking early retirement because they think they're too old and their brain just won't work like that anymore. And then I've had women CEOs that have come in and say, I'm going to get fired because my brain has stopped. I cannot function.
And what about the hormones? Is it estrogen? You mentioned estrogen matters.
Yeah.
Is it an estrogen issue, this brain fog? Do you usually see cognition come back into line after women receive hormone therapy treatment?
Yeah. So when we say hormone therapy, I'm talking usually about 3 hormones. I don't always use all of the hormones, but I often will use all of the hormones. So we're talking about estradiol, progesterone, and testosterone. I would say estradiol is very effective at managing anxiety, brain fog, sleep. Testosterone is like that plus a little bit more. About 30 to 50% of women will really see improvement in cognition on testosterone. And then the other kind of half really won't feel any difference. I will say there's women that have started testosterone and then come back and told me that it's like the lights turned on, their cognition is back. But again, some women feel that way on estradiol. And I think that's one of the difficulties in menopause care. And I get messages all day, every day on Instagram DMs, and women are looking for straight lines and right angles. Tell me what to do. What is the rule? There's no rule. All women are different. How you treat menopause is going to be different from me. It's going to be different for you. It's going to be different for the next person because all of us will react differently to the hormones. All of us react differently to different doses. There's no way of really coming up with an algorithm and a rule that you can apply to all women. Every woman is different.
Yeah, it's definitely not one size fits all.
No.
We've learned here. And if a woman is, say, she's postmenopause, what is your philosophy of starting her on hormones? I know that there were guidelines that said that you start hormones within the first 10 years of onset of menopause. What if you've passed that? What is your philosophy about that?
So I start women routinely past 10 years on hormone therapy. The 10-year window came from the WHI, where they showed that after 10 years, it seemed to be going on hormone therapy seemed to increase cardiovascular risk. But let's not forget that they used oral Premarin. We're not using oral Premarin. We're using transdermal estradiol, which does not increase clot risk, reduces inflammatory markers. So it's literally the opposite of what they gave them in the WHI. I personally do not believe that transdermal estradiol is going to, they talk about destabilization of plaques in the cardiovascular system in women that are 10 years past menopause. I don't think that applies in the case of transdermal estradiol. And maybe because I'm a primary care physician and I've taken care of women with cardiovascular disease and post-stenting and post-valve repair and coronary artery bypass graft and strokes, and it's at my fingertips. I'm very comfortable taking on that level of risk. But I personally do not believe that transdermal estradiol increases cardiovascular risk after 10 years. Full stop.
So a woman who is, say, 60, because the average age generally is 50, 51 for going into menopause, what can she say to her doctor in order to advocate for herself if she's, say, 60 years old and wants to start hormone therapy?
First of all, take stock of her symptoms. So, what are her symptoms that she's coming in with? What are her worst symptoms? One of the things that I think doctors like to do is assess cardiovascular risk and then make a decision about whether or not this person can have hormone therapy, whether or not they have increased cardiovascular risk. And so, one of the things they do is a CT cardiac calcium score. Have you ever heard of that? So
Yes.
it's a CT scan of the heart. Where they're basically looking for any calcification in any of the coronary arteries. And you get a number from 0 to thousands of your risk of cardiovascular disease. And some doctors want to see that and want to see that your risk is low before they'll prescribe hormone therapy. Again, I don't believe that there is an increased risk, but some want to see that. So I would suggest knowing what your symptoms are. I would suggest considering if they feel that's a concern, suggesting that perhaps doing a CT cardiac calcium score and some lipid panel labs would be appropriate and make them feel more comfortable prescribing HRT in that setting. And also, I think if the PCP doesn't know about this, perhaps directing them to some information. The Menopause Society has nice clinical pearls, maybe printing some of that off and bringing it with you. I know people get really frustrated thinking I'm trying to educate the doctor. If you want the care at your PCP's office, I think this will change in the next 10 years, but right now it's going to involve really advocating for yourself and maybe doing some education of your provider.
Yeah, that's great, great advice. I know the Menopause Society has great information. I also want to do a shout out to the nonprofit Let's Talk Menopause, on which I sit on the board. They have symptom trackers. They have talking points that you can print and take to your doctor. So thank you so much for mentioning the Menopause Society. You mentioned heart health. Let's go there. We know heart disease is the number one cause of death for women, especially after menopause. That's why this care in this deeper investigation of heart health is taken before getting on hormone therapy. But what changes physiologically increase cardiovascular risk? And what you mentioned earlier, some heart health labs that seem to be new in the lexicon of labs. Maybe they're not standard. Lipoprotein A and lipoprotein B. Should we ask for those proactively?
Yes. So a lipoprotein little a, so it's in parentheses little a, is actually a genetic marker of cardiovascular disease. I think it's really useful even as a one-off because it's going to give us an idea of whether or not you carry that genetic risk of heart disease. Once every 5 years, I don't think you need to do it significantly more. Apolipoprotein B is a particle in our LDL. So LDL is the lipoprotein that we call the bad cholesterol. People call it the bad cholesterol. HDL is the good cholesterol. But for the sake of this conversation, apolipoprotein B is a particle in the LDL that increases our risk further, our cardiovascular disease. Now, this is something that is movable. So, for example, treatment with statins, we've seen can reduce apolipoprotein B. Changes in our health, eating better whole foods, exercising, we can see changes in our apolipoprotein B. So that's a useful test to have. I usually do it for my patients once a year because I like to see the trend going downwards, especially in somebody that has high apolipoprotein B. I will say, you mentioned, what are the changes that are happening? Essentially, the changes that are happening with the loss of estrogen is that we develop what we describe as the metabolic syndrome of menopause. And that involves visceral fat being deposited in our abdomen. So the change in the way we deposit fat, and visceral fat inside our abdomen, that's the fat that's inside and around our organs, is pro-inflammatory. It increases our inflammatory risk. It increases our insulin resistance. It increases our cholesterol. It really is a perfect storm of cardiovascular disease that starts to develop in the setting of the loss of estrogen. And we see women go from having a very low risk of cardiovascular disease pre-menopause to a sudden sharp increase around age 50 because of this metabolic syndrome of menopause.
So once a woman has those heart, and you also mentioned lipid markers that are so indicated in cardiovascular risk, how does she know when it's okay to simply track numbers and when it's time to take action through either lifestyle changes or specialized medical support with a cardiologist? I'll give you my example. So I've done the lipoprotein B. I've done it 3 times over a period of a year because it was high, then it went low, and then went back up again. My cholesterol markers tend to be high. I'm doing all the things, Dr. Noor. I'm lifting weights. I'm watching my diet. And my doctor says, let's just keep watching it. Let's keep watching it. But it's been a year that we just keep watching. Should I go to a cardiologist and really assess my risk at a deeper level?
So assessing your risk on a deeper level, other than the lab parameters that you have, is about your family history. That's a big one for me. If I see a woman and she's 60 and she has not great lipid parameters and maybe her visceral fat is increased and her mother died of heart disease, she's somebody I'm going to be like, okay, we need to intervene and we need to do it now. If she comes from a genetic line of people that lived to their late 90s and 100 and we're doing all the things, then maybe I'll take a different approach and take a more monitoring approach. But that's definitely very individual. And don't forget that in many cases, especially in genetic hyperlipidemia, so high cholesterol that's genetic, yes, there's medications like statins, which we use routinely, but it's important that we take all of the risks together to see what else we can assess. So alcohol use. Are you sleeping? What's your stress level? Are you smoking? What are the other risk factors that we can essentially nullify and get rid of in the setting of us knowing that you have genetic hyperlipidemia? Because we know that cardiovascular disease does not only come from cholesterol. There's plenty of 90-year-olds never had a heart attack with really high cholesterol, right? It is a multifactorial disease. So when we take all of those factors and make sure that we can isolate and get rid of as many risk factors as we can, maybe we can live a little bit longer with that cholesterol and watch it.
And that's where, as you mentioned earlier, lifestyle is so important. The sleep, the exercise, the nutrition.
Yes.
I'm doing all those things, Dr. Noor. And I think I come from the latter group where
Yes.
I have a genetic disposition, and women and men in my family have lived to be 90, 100 years old. I have that in my favor, I hope. But if that's not your case, if you do have a family history of cardiovascular disease.
That's a different situation. When somebody says to me, my dad had coronary artery bypass grafting at age 65, and I'm going to want to be intervening earlier and saying, okay, I'm not prepared to sit on this in terms of your cardiovascular risk. We need to do something, and we need to do something now because I'm worried that those changes are happening in your cardiovascular system now as opposed to in 10 years or 15.
Thank you so much for that. So let's move on to metabolic health, because you mentioned this. It's such a big concern. You mentioned the weight changes, especially around the middle, more insulin sensitivity with many women managing prediabetes or bordering diabetic, type 1, type 2 especially. What's really happening with insulin sensitivity after menopause? And you mentioned the lab markers earlier. Maybe we can just mention them again. What lab markers best reveal early metabolic red flags, and what solutions do we have for addressing them?
What happens when we lose estrogen? So, the thing about estrogen is a beautiful hormone and is involved in so many functions in our body. And it's very involved in the function of insulin. What is insulin? Insulin is a hormone released by our pancreas in response to a rising glucose. So you eat an apple, Gabriella, your blood sugar rises, your pancreas detects that, it releases insulin into the bloodstream. Insulin goes all over the body, binds the insulin receptors, opening a channel, allowing the glucose to flow from the bloodstream into the cells and tissues, which is where we need it. Me and you are currently using glucose and making energy. Insulin is a fundamental function of our existence to move that glucose into the cells and tissues where we need it. And then as a result of that, our blood sugar levels comes down and order is restored. What happens when we lose estrogen is we become insulin resistant. What do I mean by that? You eat an apple, Gabriella, your blood sugar rises, your pancreas detects that, it releases insulin to the bloodstream, and nothing changes. Nobody's listening. Those receptors that were so sensitive to insulin and opening and closing at a drop of a hat are now quiet and they're not responding. So now we have a situation where our blood sugar is staying high. So our pancreas says, oh no, the blood sugar is still high. We'll release more insulin. We'll release more insulin. We'll release more insulin. So now you need significantly more insulin for that one apple than you did 10, 15 years ago. And the problem with insulin is a fat making hormone. Insulin helps and promotes the deposition of fat. That's how it functions. And if you've ever known anybody that's type 1 diabetic, you'll know that they can manipulate their weight with their insulin dose. The higher their insulin dose, the more weight they'll gain. The lower insulin dose, the more weight they'll lose. Because there's a direct correlation between insulin and fat deposition. So if you're in a situation where your insulin is high consistently, because nobody's listening and your body's trying to manage its blood sugar situation, your body is laying down fat as a result of that insulin being present. And a lot of that fat is that fat inside our abdomen, right? And that visceral fat, not that we can feel, but that's inside our abdomen and around our organs. So that's what we're talking about when we say insulin resistance and the change that we see from being very insulin sensitive to very insulin resistance as we go through menopause and lose estrogen. When you think about the development of type 2 diabetes over many years, at the very beginning, you start to have insulin resistance. So your tissues start to not listen very well, and your pancreas is releasing insulin, trying to chase this blood sugar, but it's keeping it under control. But it's having to have a high insulin to keep it under control. So what we're seeing is a high insulin and a normal blood sugar. And that can limp along for a while until you get to a situation where your pancreas is not able to manage that insulin, can't manage that high insulin level. So the insulin level starts to drop, but now it's not controlling the blood sugar. So we see the blood sugar start to rise and type 2 diabetes develop. And this is we see over the course of 5, 10, 15 years. So one of the things people tell me over here is they say, oh, my blood sugar is normal. My doctor said my blood sugar is normal. But actually, what I want to do is a fasting insulin because they might be in that early stage where their blood sugar looks normal, but their insulin is working really hard to keep it. So I mentioned doing an insulin resistance score where we check a blood sugar, a hemoglobin A1C. The hemoglobin A1C is a blood sugar over the last 3 months. So it's an average blood sugar reading that we like to use when we're assessing response to medication, especially in a diabetic patient. So we do a blood sugar, a hemoglobin A1C, an insulin, and then something called a C-peptide. And a C-peptide is actually when we make insulin in our pancreas, it's attached to C-peptide. And when we release it into the bloodstream, we cut that C-peptide off and send the insulin to the bloodstream. So checking the C-peptide level is another way of seeing how much insulin you're making. So taking all those parameters together, we can come up with a score called an insulin resistance score.
And then what solutions are there, say, for a menopausal woman, her HbA1c is creeping up there to pre-diabetic range. Do you just watch it? Again, I've been told that by doctors. Let's just watch it. Let's just keep an eye on it. How long do you keep an eye on it? And when do you take action and how do you take action?
So we start with lifestyle. I have a dietitian on staff that works with my patients, specifically that are pre-diabetic, on really trying to achieve a low insulin lifestyle. The other thing that's really useful is a continuous glucose monitor. People get all upset when I talk about continuous glucose monitors in patients that are not type 2 diabetic, but I think they are so useful. And I don't want that my patients to be using them indefinitely, but I like them to use it for at least a month just to see what's happening. Because sometimes I'll say to them, you're insulin resistant. They're like, no, I feel fine. My blood sugar is normal. And then we put the CGM on them, and actually they're spiking in the middle of the night. They're spiking early morning. And then they start to see the pattern of their behavior and their blood sugar. And it's really important that they see the relation between those two things. It's funny because then they'll call me and they'll say, oh my goodness, so I just realized if I take a 10-minute walk after dinner, my blood sugar is normal.
Exactly.
And I'm like,
Exactly.
yeah, I told you. But if I've been telling them to do that, but until they see it on their phone, in their app, in black and white, they nearly don't believe me. So getting that real life, real time data back is so useful for somebody that's insulin resistant.
I'm so glad you mentioned that because I resisted the CGM for so long. I'm like, why do I need it? Why I need it? And finally I gave into it and I did it. And it was so eye-opening. I mentioned before we got on that I moved back to Texas where I'm a little bit more sedentary because we need a car. I moved from the UK where I was constantly walking with my groceries and now I'm in a car more often. We have amazing Tex-Mex food here, so I love my tortillas and my tortilla chips, but I noticed with the glucose monitor how
Right.
just a handful of tortilla chips would
Yeah.
spike my blood sugar
Send it.
level. And then how if I went for that walk, and that's a habit I'm really trying to start religiously, and it's hard, right? Because things get in the way, like after every meal, or at least after my morning meal, after my evening meal, go for just a 10-minute walk on the treadmill in the evenings. I saw you with your walking mat.
Oh, I love my
That's
walking pad.
I don't have one of those, but I think that's a great solution, if especially
Yeah.
in the winter now, just keep
Mhm.
like a
Mhm.
walking treadmill mat in your office
Mhm.
and a little bit of movement, 10 minutes. I saw that in real time on my CGM lowering, and
Yeah.
it's an incredible tool. It really is. And I did see my HbA1c scores drop after a 3-month period of having the CGM because I had it on for 3 months because I'm like, "I'm gonna nail this. I need to figure out this thing out." And
Because your behavior changes. In and of itself, it's an intervention.
I'm so glad you mentioned that. I think not enough doctors mention that and really insist on
I
it.
love
So
the
good.
CGMs. I think that they're so useful. But as I said, people get all upset about that. The other thing
Mm,
that I talk about, again, we're back to building muscle. Muscles love glucose. And if you have a lot of muscle and you dump glucose into the bloodstream, the muscles will suck it right up. They love it. The more muscle you have, the more you're going to keep your blood sugar low. So the more muscle you have, the more insulin sensitive you become. And we see that in real time with patients because we partner with a weightlifting gym and we'll send them to do weightlifting and they'll come back in 3 months and their A1C is better because it's such a simple intervention. Not simple.
mm.
It's hard. It's not medication, right? It's not taking medication. And that's for some people really important. They don't want to take medication. They want to do as much lifestyle measures as they can. And to be honest, and I don't know if you experienced this, Gabrielle, but I've seen patients just starting testosterone and estradiol, their blood sugar also and their metabolic parameters do improve. And we know that because physiologically we know that insulin sensitivity and estradiol are linked.
Definitely, I've noticed I have more energy to go to the
Mhm.
gym and more
Mhm.
motivation to go to the gym. So I've definitely noticed, yeah, a downturn in those blood sugar parameters. Let's talk about weight for a moment because it's such a charged topic in midlife. You mentioned it a couple of times. I'm of the belief that our bodies are meant to change and that there's a certain level of acceptance that comes with aging. I'm doing all the things. My body's not going to go back to its 20, 30-year-old version. I'm coming in to that acceptance that it's going to look different, especially when I'm doing all the things and I know I'm doing the right things. But yet, so many women experience midlife weight gain and feel like it's such a personal failure when you're explaining it's really often biology, right? We've entered this new era now of weight loss medications like GLP-1 drugs. From your perspective, who is actually a good candidate for these treatments and how do you guide women in deciding whether this is an appropriate tool for them?
One of the tough things we have with GLPs and the negative connotation around GLPs is people assume whether or not somebody is a candidate for GLPs based on looking at. For example, you look very fit and you just told me that your blood sugar parameters have been abnormal. We make decisions about whether or not somebody's a candidate for GLP-1 based on their metabolic parameters, their DEXA scan, what is their visceral fat. So there are far more people than people think that are candidates for GLP-1s because of their body composition, which you can't see, you don't have x-ray vision. That's the first thing that I will say. People will say, you don't have anything to lose. This is not about weight loss. This is about body composition. This is about your visceral fat and cardiovascular risk and your blood sugar. So far more people are candidates for GLP-1 than people think are candidates for GLP-1s because they assume GLP-1s are only for people that are obese from a BMI perspective. But that's not true. There are many more people that metabolically would benefit from GLP-1s that do not perhaps look obese.
So you don't see them only as a weight loss drug?
Oh, yeah. The effect that it has on cholesterol, I have to say, I think is currently underreported. I think we have seen improvements in apolipoprotein B, lipoprotein little a in women, I think far greater than I would have seen on a statin. So back to a woman, for example, that she is struggling with high cholesterol. She maybe has her blood sugar is a little bit abnormal. Maybe she weighs 138 pounds, doesn't really matter. And maybe because her blood sugar is a little high, her visceral fat is maybe a little bit higher than we would like it. Even though she weighs 138 pounds because of her metabolic risk, I might say, okay, we've done the CGM, we're working on building your muscle, but we're just not getting ahead of this. Maybe this person is now a candidate for GLP-1, not for the weight loss, but for the metabolic parameters.
And would you start her off at a very low dose? I've heard of some of the side effects of the GLP-1 drugs.
So it's interesting because some people have side effects. Some people have nausea and and constipation, and then others, nothing. And back to talking about women and hormones, everybody's an individual. There are no real rules around it. You can't say that this person's going to have nausea and constipation, the next person. You just can't predict these things. You don't know who's going to react whatever way. Back to dosing, people again love to get upset about when we use the word microdosing, but the fact is we've been using microdosing as long as there have been medicine around. We've tailored medication doses to the patient's response. And for some women, and some not just women, and men, they respond to lower doses. For example, a perfect example is blood pressure medication, like amlodipine, for example, been around for 1,000,000 years. Lowest dose is 2.5 milligrams. So for some people, that's too much. And you need to, I tell them to cut the pill in half, take 1.25 milligrams. And that's just how they're made and the way that their pharmacokinetics are. So why doesn't this apply to the GLP-1s as well? Yes, some people won't feel anything and will be on a 10 milligram dose, but some people will feel a lot and need half of a 2.5 milligram dose. So that's going to vary widely from one individual to the next. The lowest effective dose, basically.
Okay. And when you're looking at strictly for metabolic balance, not weight loss, is there a specific GLP-1 that you turn to?
I like to use tirzepatide right now. I think the newer ones are going to be amazing that come out that are going to be even more effective. But Zepbound seems to have less side effect profile than Wegovy. So I will usually start with Zepbound. There's some insurances that want us to only use Wegovy, but I will try to start with Zepbound where I can. And we start at the lowest dose. And sometimes one of the beauties of now being able to prescribe the single-use vials from Eli Lilly for Zepbound, I send them a prescription and they send the patient a box of 4 single-use vials at the 2.5 milligram dose that they could then drop and inject themselves. The patient can drop half of that. They have the ability to say, I'm only going to take half of this vial and not the full vial. So they effectively can microdose the Zepbound if that's, again, the lowest effective dose for them.
So Zepbound is the pharmaceutical name for tirzepatide.
Correct. Zepbound is the pharmaceutical name for tirzepatide. Wegovy is the pharmaceutical name for semaglutide.
Okay. And Mounjaro?
So Mounjaro is also Zepbound. Tirzepatide is the drug. Zepbound is the label for weight loss, and Mounjaro is the label for diabetes.
Okay. So you look at all of those, the factors of weight loss, diabetes, cholesterol before you prescribe one of those.
Yeah. And interesting, I think one of the things we're also going to see, Wegovy is now FDA approved for fatty liver disease. We are going to see an FDA approval for alcohol use disorder. And I think there are many more indications coming because I can tell you anecdotally, people come in and see me and tell me my anxiety is gone. I'm sleeping. So there's a lot there that we don't fully understand yet. The other one is the anti-inflammatory effect. People are like, with the history of rheumatoid arthritis and their joint pain's gone. It's really interesting.
Fascinating. I would love to take a deep dive on these medications at some point here on the podcast. I haven't done that yet, but I'm learning. And thank you so much for walking us through that. I've learned a lot from you about that. Let's move on to another foundation for longevity, and that's bone loss and muscle loss, which often happen quietly until there's a problem.
Not quiet.
When should women be getting DEXA scans, and what daily habits? You mentioned, of course, weight training. I think it's the biggest needle mover for protecting bones and maintaining strength long term. What do you recommend for that?
We scan women from about the age of 35.
Oh,
I do
wow,
have some that
really?
come in that are younger. I have found osteopenia and osteoporosis in women that are 35. People think that this is an old lady problem. It is not an old lady problem. Osteopenia and osteoporosis are affecting younger women, especially women, for example, with family history, perhaps with a history of an eating disorder. Perhaps they have at some point not had periods because their weight was too low. That's a very, very big risk factor, with a history of smoking, with a history of alcohol use. So osteopenia and osteoporosis can affect quite young women. And it's important that we know that early, because if we know early, we can intervene early and prevent progression. But at the moment, and if you want to wait for insurance to cover it, you're going to start being scanned at age 60, some 65. And really, the majority of women have actually fractured before that.
So that's way too late, right? So
It's way too late. Scanning women early.
So this is something every woman should go in and ask her doctor about. Is it very expensive?
No, it's not. And you can go online. There are a number of different, if you just Google DEXA near me, there's a couple of different online options for booking, and it'll show you the nearest DEXA scanner to you. And you can generally get a DEXA scan for bone density for about $150. It's not crazy.
So worth the investment, just to
Mhm.
have that knowledge that you're not going down that path and to take action. And the best protocol, if you do find someone who has osteopenia, early osteoporosis, is what intervention?
Again, take a full history. Can we figure out why? Is there something in the history? Is there family history? Does she have a history of premature menopause? What is going on? Do we have any reason we can see in the history that would be causing or potentially impacting bone density, and addressing that? So whether that's she's not eating, she has an eating disorder and she's not eating, whether that's she has another endocrine problem, whether or not she is very sedentary, she's a heavy smoker. We need to intervene on all these counts and figure out, is there anything obvious? Is there a red flag in her history that we can intervene on? But
Mm.
if there's nothing, I would start by, if this woman is of the age that I think that she's likely perimenopausal, we need to intervene early with hormones, because we do not want her to go through that. What we see, there's a sharp decline in bone density in perimenopause, long before your last period. We need to intervene with hormones early to really try to get a steady state, so we're not seeing that decline in bone density that we see in perimenopause. So intervening early from a hormone perspective, adequate nutrition, vitamin D, ensuring adequate calcium, exercise, particularly weightlifting and jumping. So
Yeah.
rebounder, box jumping, significant impact on bone density.
I recently started jumping. It's hard, but I start with even with little bunny hops. That helps, right? Little bunny hops, or trying with the jump rope. Although with the jump rope, we run into the issue of leaking. So let's go there. Sexual
Mhm.
health. Your clinic focuses on sexual health, which I
Yes.
love. We talk a lot on this show about sexual being as a vital sign of midlife health, yet so many doctors don't bring it up, especially PCPs, and many women don't know how to ask. So how do you start that conversation, Dr. Noor? And why is supporting vaginal health, urinary health, and sexual desire so important for quality of life after menopause?
Mhm. So I'm going to take that separately slightly and talk about urinary health first of
Okay.
all.
Yes.
And urinary incontinence, it really affects, I would say, the vast majority of women. Some form of urinary incontinence, whether that's stress, urge, or mixed, is going to affect most women. And most women are like, this is my lot in life. I had 3 children or 5 children or whatever. And so that's the first thing, intervening with vaginal estrogen early to prevent further decline in our urinary symptoms, and also try to restore our vaginal health a little bit so that we improve our incontinence. Also, seeing a pelvic floor physical therapist. So that's really useful for women that are having incontinence. So those are the two things I would say from an incontinence perspective. And it is a life or death problem. Women are dying of urosepsis because of recurrent UTIs, because they've been on every antibiotic under the sun for 20 years for their UTIs, and they stop responding and they die. And that doesn't have to be that way. a simple intervention with a little bit of vaginal estrogen. It is life-saving and safe. So that's the first thing I'll say. From a sexual health perspective, I will often ask about libido, and I get very interesting answers sometimes, but people will say to me, I have no interest in having sex. And then I usually follow that up with, but do you want to have sex?
Mm.
Is it important
Do
that
you
you would
miss it?
want to have
Yeah.
sex? Do you
Yeah.
miss having sex? You want to, or do you just not want to, or you hate your partner? Or because that's also some people are like, I'll sleep with the next door neighbor, but not my partner. And I'm like, okay, I get that now. And women say all sorts of things to me. So that's the first thing, is to establish if this person wants to have sex. The second one is, when we talk about libido, is why. It's important that is it a physical thing? Does it hurt? Is it been so unpleasant when you've had sex that now you're just like cringed like this because you're so worried that it's going to be painful? Can you feel? A lot of women lose a lot of sensation down there. They can't orgasm. They can't feel. So is there pain? Can you feel? And then you mentioned our own view of ourselves. That can have a big impact in confidence and self-esteem. Is that the big issue? Do we need to help you feel better in your body and about your body so that you feel like a sexual being again? And then there's the hormone. We know that you lose estradiol, you lose testosterone, and your desire just disappears. And I have women really, they feel terrible about it. They've gone from being people that would have intercourse daily or every second day, and that was their life, and they were sexual beings and they loved it, to having no interest. And this whole part of their identity, they feel like they've lost.
And you can get it back with the help.
Totally.
Hormones,
Yes.
pelvic floor therapy, vaginal
Again,
estrogen.
let's fix. Can you feel? What can we do to fix that? Do you have pain? What can I do to fix that? Whether that's medication intervention, which we will generally use topically and locally to the area, and then pelvic floor PT. Also, my life coach has a lot to say about this, and really perhaps the relaxation, intimacy, connection.
Mhm.
And she's really useful when we're having a real conversation with somebody that's really struggling with this. And then hormones have a big impact. So starting hormones, people talk a lot about testosterone and the effect on libido. I actually think estradiol has a profound effect on libido, testosterone also. So getting those where we need them to be, to see if that can improve the situation. And if not, then I would also consider a non-hormonal option like Addy or Vyleesi. And I have some patients on those that do very well. One other thing I will say about libido, and one of the issues that I see, is by the time women make it in to see me, they've been put on an SSRI. They've been put on an antidepressant medication for their symptoms, for their, I don't feel like myself, I'm anxious, I can't sleep. And that's not wrong. In my opinion, it shouldn't be first line, but that's not wrong. But the problem with these drugs is they, number one, have a significant impact on libido. And number two, they have a significant impact on your ability to climax. And in fact, we use it in men with premature ejaculation to make them last longer. So in men, we use it to make them last longer. And when you give it to women, they can't orgasm. It's so hard to orgasm. So one of the things I also need to do sometimes is try to de-escalate the dose, and ideally, if possible, get them off the medication entirely.
That's so interesting. Yeah, I didn't know that about the SSRIs.
Mhm.
And I know also that your life coach focuses on nervous system regulation
Mhm.
and mindfulness. We
Yeah.
talk a lot about that here on the podcast. We had Dr. Lori Brotto, sex researcher, talk about the power of mindfulness to increase desire in women. And we always also say here, it's not necessarily about engaging in your traditional kind of penetrative intercourse, but really about feeling that sense of vitality and aliveness in your body that you can experience when you tune into sensation, when you tune into touch. I find this stage of life is a wonderful opportunity to redefine what
Mhm.
sex and pleasure looks like for you. And yeah, if you do want to have penetrative intercourse, there are so many solutions, all of which you have mentioned. And sexual health is an integral part of our overall health and vitality. And I so love that you have included it as part of our midlife vitality blueprint. So before we say goodbye, I want to just address one more topic, and that's supplements. Women are bombarded with supplement marketing. But from an evidence based perspective, which supplements do you consider are truly foundational and which are often unnecessary or overhyped? I know there are probably more that are unnecessary, overhyped than what are essential.
There's, in my opinion, only one. Women, especially where we live, need vitamin D supplementation. The vast majority of them have low vitamin D, and it shows in their bones. So the only, for me, non-negotiable is vitamin D, unless somebody has a really high vitamin D, which I've yet to find. So the only non-negotiable is vitamin D. Everything else is a conversation. For example, if I have somebody that has some cardiovascular risk factors, so we're talking about heart health, maybe we talk about omegas. If I have somebody that's really struggling with fiber intake and their visceral fat is high and we're really trying to work on their blood sugar and we just can't get their fiber intake where we want it, maybe we supplement with a little bit of fiber. If I have somebody that's really struggling to relax at night and go to bed and settle, I might talk about magnesium. If I have somebody that's B12 deficient, or maybe they're vegetarian or vegan, I will usually recommend a B12 supplement. I don't have a list of, I want you to take all of these supplements. Number one, it's complicated and you just can't maintain it. Number two, it's so expensive and entirely unnecessary. We try, where possible, for you to get all of your essential nutrients from food. If we can't achieve that for whatever reason, we will then plug in the holes with a supplement. But the only non-negotiable in my practice is vitamin D.
And then case by case based on other symptoms.
Yes.
Wonderful. If a woman listening wants to start building her midlife vitality blueprint right now, what first 3 steps would you invite her to take? You mentioned the vitamin D. I think I agree, essential. What other steps would you invite her to take?
Figure out how you can exercise. You need to find something that is achievable and you can maintain. Some form of weightlifting. And that's going to look different to different people. Some people like to exercise in a group. Some people like to exercise by themselves. You need to figure out what works for you and you need to do it and stick to it. Get a DEXA scan. You need to know what your bone density is. Ideally, also do the body composition part so you know what your muscle mass and visceral fat is. I would say those are the biggest bang for your buck things that you can do that can improve your long-term health.
Thank you so much, Dr. Noor. This has been such an empowering and practical conversation. I've learned so much. Thank you for helping us design our midlife vitality blueprint, one that really reminds us that we're not just aging, we're actively shaping how we live for decades to come, and we have the power to do that. Before we wrap up, let our listeners know where they can find you, learn more about your work, and stay connected to your educational content, which I think is amazing.
Thank you. So I'm online. I'm on social media, Instagram and TikTok as Ask Dr. Noor. And my website is drnoorwellness.com. And then my practice website is lifestylesbynoor.com.
Thank you so much, Dr. Noor, for your voice, for educating us in this topic. You are truly changing lives. Thank you so much for being on the show today.
Thanks.
Thank you for joining me for this episode of Pleasure in the Pause. Want to help me spread more pleasure in the world? Please hit subscribe to the podcast and share this episode with a friend, a sister, or any woman you care about. Because when we share these conversations, we remind each other we are not alone. Together, we create ripples of empowerment and support that reach far beyond ourselves. Your support means the world to me. Thank you. Remember, your pleasure matters. The information shared on this podcast is for educational and informational purposes only and is not intended as medical advice. Always consult your healthcare provider before making any decisions about your health or treatment. The views expressed by guests are their own and do not necessarily reflect the views of the host or Pleasure in the Pause.